Hello, my name is Greg Shaw. I'm a consultant urologist at University College Hospital, and I'm very interested in prostate cancer. I do a lot of work with robotic radical prostatectomy to try and cure men with prostate cancer, and I lead the robotic urology team at University College Hospital.
Hi Greg, can you tell us what happens when a man is diagnosed with prostate cancer?
When a man is diagnosed with organ-confined or disease that hasn't spread, prostate cancer that hasn't spread, then we have an opportunity to try and cure that cancer. And thankfully, we get very good results and our cure rate is high.
Robot-assisted surgery makes it possible to spare the nerve bundles. How does it work and what are the benefits for the patients?
So we talk about nerve sparing, where we peel off the outer layers of the prostate to leave the microscopic cavernosal nerves which run in the fascial coverings of the prostate behind. And we know that through doing so, we can improve the man's chance of being able to get penile erections and be sexually active after the surgery. We also think there's an effect on the recovery of urinary continence. So we know that nerve sparing is something we should seek to achieve where possible, but it's not always possible. Sometimes the tumor is coming through the capsule of the prostate, and we know that if we try and nerve spare in those cases, then we risk leaving cancer behind and decreasing the man's chance of cure. So we want to avoid positive surgical margins, but at the same time, we want to spare as much tissue as possible around the prostate. So there's a balance.
Nerve-sparing radical prostatectomy comes with its own set of challenges. About 30% of men have higher risk of recurrence due to remaining cancer cells after surgery.
When we take the prostate out, we're not able to look at what we've left behind, only what we take out. And therefore, we examine what we call the surgical margins. What we want to see is that all of the tumor is covered with normal tissue. This is the principle of cancer surgery, and it gives us confidence that we've removed the whole cancer. And one of the projects that I'm leading on is a randomized controlled trial to evaluate a surgical intervention which takes place during the operation. It's called NeuroSafe, and it was invented by a group in the Martini Clinic in Germany who get excellent results. And during the operation, the prostate is removed and examined by a histopathologist. With the NeuroSafe technique, this is done with frozen section. So a segment of the prostate is chopped off the bit adjacent to where the bulk of the nerves are, and it's sliced through perpendicular to the surface at intervals, and then very rapidly we freeze it and generate slides which can then be stained with H&E and examined by a pathologist, so that the pathologist can give you an intraoperative frozen section margin evaluation, and they'll tell you whether there's a tumor at the edge or not, and then we can, while the patient's still asleep in the same operation, do a secondary resection, so take a wider excision in the area where there's a positive margin in order to achieve a negative surgical margin.
Current techniques are not optimized in terms of resources. What are the main challenges to be solved?
The NeuroSafe procedure takes about 40 to 50 minutes to get the result. All of this time the patient is asleep. Thankfully, the increased duration of surgery doesn't seem to bring about an increased rate of complications, but there is a resource and cost issue associated with that. There's also great technical expertise required to produce the slides, and of course you need a pathologist available to look at the slides during the course of the operation. So it's relatively labor intensive and in reality expensive to perform this procedure.
How can the Histolog scanner be helpful in nerve-sparing radical prostatectomy?
The process by which we evaluate the margins intraoperatively, as I've said, is done with frozen section, which is time-consuming, expensive, It takes technical expertise. And we also evaluate the margin by cutting through the prostate perpendicular to the edge. So in effect, we only examine the edge of the prostate at intervals of 5 millimeters or so. So we're not looking at the whole surgical margin, we're looking at a sample of it. My interest in confocal laser microscopy comes from the ability to examine the entire margin of the prostate. And the images seem to be generated much more quickly than the results of the frozen section. The speed at which a large image, which can be zoomed right into to microscopic levels, the similarity of the images when compared to H&E stained pathological slides is encouraging, because we're used to interpreting that, at least our pathologists are. So there's a lot that makes it an attractive angle.
The Histolog scanner is an easy-to-use device for the operating room. It provides a global mapping of fresh specimens in just 5 minutes with histology-like resolution.